to the OT Help Desk YouTube video series. And today we're going to talk about the total hip. Yeah, we're going to do the anterior and we're going to do the posterior. We're going to break them down and then talk a little bit about occupational performance and its impact. So I'm Big J.
I'm Little J.
And we're off to the races. So, you know, it's important, first of all, to understand the diagnosis. So let's say we're going to start with an anterior, okay? Anterior hip replacement surgery, all right? Now, when we look at that diagnosis, anterior hip, and we go to the etiology, usually some sort of breakdown, osteoporosis, osteoarthritis, okay? You laughing at my osteoporosis? All right, or
just a little bit.
All right, okay, all right. So I'm sorry, it just got a little caught in my mouth there. All right, but so what we've got is we've got a hip surgery on the anterior, clearly coming in from the anterior side. The benefits to anterior are they start at the iliac and they come down to the thigh, and then they work from here in. All right, so what you get there is less, less, shall we say, invasiveness to the muscles because they strip the fibers and they go in. So that's an actual, and there's different reasons why they might do it. Some surgeons, would prefer to do anterior versus posterior, and they have their reasons. Now, the posterior lateral is going to start, and it's a curve that usually starts on the outside, the lateral moving towards the posterior, and then circles around. So it's important because they're usually approaching the trochanter area from behind, okay, versus the front where they'll hit the anterior aspect, okay, moving in. So the surgery itself, okay, doesn't take that long. I mean, I remember years back, and I'm telling you years back, guys, 1986, 87, yeah. People were in hospital for 3-4 weeks. And now today, my gosh, you're in and out pretty quick. Yeah. So let's talk about the things that people experience after the surgery when it comes to client factors. Because we know what the prognosis is. The prognosis is really good, okay? But what kinds of client factors, what kinds of issues do people have with both posterior and anterior?
So one of the biggest things that we're going to see, of course, is pain. They're going to have pain with their joint movement, with their range of motion. Okay. That's one of the largest client factors. And then we also have to consider the restrictions in joint mobility that they're going to have. Not only from the perspective that pain may be causing limitations in their joint mobility, but we also have to consider the fact that they're going to have joint range of motion restrictions. There's going to be certain movement planes that they don't want to move that lower extremity into.
It's good that you brought that up because let's think about anterior and let's think about the movements, okay, and kind of understand why the movement would make a difference.
So with an anterior hip replacement, there's going to be 3 that we don't want to do. We don't want to do external rotation, we don't want to do adduction, and we don't want to do extension past neutral. I like the demonstrations.
All right, I'm getting there. I was just thinking through it in my head there.
So again, no extension past neutral, no adduction, and no external rotation.
You're going to really have to help me understand that. Extension past neutral. Extension of what?
Extension of the hip. So that would be, for example, if I'm standing up here, this would be extension past neutral would be back.
Good. So. Extension past neutral. Got it. All right. And then a deduction is
coming together. That's
coming together. So don't put your legs together.
Exactly.
Keep them apart. Okay. And then the other one?
And there was no external rotation.
And that's basically this puppy here, right? External rotation.
Exactly.
All right. So not a good thing. Now think about that. No external rotation. We have a surgery anteriorly. So if you should happen to externally rotate, okay, you're going to pull it out and away from its home base, from home base, baby. Yeah. Okay. And extension, if I pull it back, if I'm going back, okay, you're going to push the head anterior and out the door, which is not what you want to be doing. Right. No, doctors don't like that. No. All right, so that in of itself, we get the instability based on the surgery. And it takes, a good 6 weeks, okay, until somebody comes around and they're really ready to go. And we'll talk more about that as we roll. Let's do posterior. Are there any differences in posterior with regard to, the movements?
Yeah, absolutely. So for posterior, the commonality between the posterior hip precaution and the anterior hip precaution is no adduction. So that's in both of them. You don't want to adduct.
Got it. No adduction, both.
And posterior hip replacement, with those precautions, you don't want to internally rotate. So versus the anterior approach where we can externally rotate, now in the posterior approach, we don't want to internally rotate. And then the last one is we do not want to flex past 90 degrees. So with the posterior approach, no flexion greater than 90 degrees at the hip.
Okay, so right this minute, if I look at you, okay, are you flexed past the 90 degrees?
I am absolutely breaking the precaution.
So I go to my patient's house, right? I walk in the door and he's sitting on the sofa. He just had a total hip. He had an anterior or a posterior lateral total hip replacement. He's sitting on the couch, okay, and his butt is down in the couch and his knee is up in the air. I looked at him and I said, oh my gosh, and he looked at me, he said, what's the problem? What's the problem? I said, you're breaking hip precautions. He had no clue, okay, what it meant for hip flexion. So you really have to remember, your butt goes below your knee, sitting here at 90 degrees, your butt's below, and you're now flexing more than what you're supposed to be. You're probably right now at about 100 to 110.
Right.
And that's too much. Now, why? Why for a posterior? Think about it. If the actual, the way it's set up and where the surgery is here to the back, okay, and you're doing this, what you're doing is you're driving through the trochanter, you're driving the head all the way back, and it literally will pop out, okay? You don't want to have that happen, because I've been around with patients, okay, who didn't follow their precautions, and the docs have to go back in, and many times the surgical, to fix it is a lot more extensive than what they actually did to replace it, okay? So, so we have this, and we have an idea of these elements. Let's go to what we do. Let's go to what OTs do, right? We're going to be thinking about occupational performance. And what we want to do is we want to apply the rationale, the logic behind this.
Got it.
So what kinds of things, shall we compare and contrast anterior, posterior, or do you want to do just one at a time?
Let's talk about posterior.
All right, let's do posterior.
A lot of the times that's going to be the ones where, in the context of our ADLs, we're really going to have to think about how we can initially compensate and adapt, considering how this is going to affect our lower body ADL specifically. So is there one you want me to start with?
Let's talk about just the idea of getting up and down.
Sure. So when you're doing a transfer, what you're going to do is you want to make sure that they kind of extend at their operated extremities, so that when they stand, they're not going to be breaking their hip flexion precaution there. So we call it kind of kicking that foot out. So if you kind of instruct them to kick the foot out, extend at that extremity here, and when they stand, that's going to prevent them from breaking the hip flexion precaution there.
And I always tell them nose over toes.
Nose over toes. And one of the other things you want to think about is sometimes we will train our clients to rock to do their transfer, and we do not want to train our clients to rock to do their transfer. We want to make sure that they're, still getting nose over toes to make sure they're not going to go falling backwards, but you don't want to have them rock because that places them in an increased risk of breaking their hip flexion precaution.
And guess what diagnosis can be a real problem with rocking? Parkinson's. Yep. Parkinson's is one of those ones, excuse me, where you're teaching them to rock so that they can move.
Yep.
Okay. And at the end of the day, they can't do that with the posterior lateral.
Exactly. And you're going to do the same thing before you sit down. You're going to have them to straighten out again, kind of kick out that foot, extend that operated extremity, and then they're going to reach back and have a seat.
All right. So that's getting up and getting down. What other things do we think about with the posterior lateral?
Gosh, I would say lower body ADLs is probably the biggest thing in terms of lower body bathing and lower body dressing.
Oh no, this is where your OT comes to your room and they have that little bag, and in the bag they have the long-handled sponge.
The long-handled sponge.
The reacher.
Exactly, use the reacher to help thread your pants.
And the shoe hole.
Yep, the shoehorn prevents you from having to bend over. You can also use something like elastic shoelaces, because that way you don't have to, because think about it, the normal way someone would tie their shoes is that either they would bend down to tie them or they would cross their leg to tie them, and they can't do either of those with that approach. So you could talk to them about elastic shoelaces that they could use that would prevent the need from doing that.
And then you have the SDB, the Sock Donor Baby.
Oh, the sock donor.
The Sock Donor Baby is, which is just the most famous, easiest thing. We never purchased them. I'm going back a long time, my friend. Okay, we had an old bucket. They were what spackle came in, the stuff they put on the walls, and we would cut a lip out of it. Okay, cut it out with shears. Okay, put 2 holes in it and put 2 pieces of rope on it, and that was our sock donor. And we put a little piece of Velcro loop on there, and then you'd put your sock on it, and off the races you go. That was cheap. I mean, it was almost nothing. Okay, compared to now, my gosh, the prices of these things, it's just ridiculous. But a sock donor is one of the ones. So sock aid, he's calling it an aid. I called it a donor.
And then we got the dressing stick too. You can potentially use to help unthread your clothes and to take off your socks and shoes.
Oh, watch one of those questions where it talks about somebody who has, issues with, some type of skin, where the skin could break down or something of that nature, because those
exactly. And you can use the reacher as an option to unthread, but like John was saying here, it has the part on it that's not exactly the most friendly to skin, to your skin integrity. So if you have an older individual, which the odds are that the individual you're going to be working with that's had the hip replacement is likely to be an older adult. So you want to make sure that you're taking into account their skin integrity with the equipment and making sure you're training them to be safe with it, to make sure that they're not going to get any skin lacerations from using the equipment.
Quick story. I had a patient who had diabetes and had a lot of peripheral issues to their legs and had a total hip. And I went to watch him use the long handle, dressing stick, and he wasn't using the end with the dressing.
Oh, he was using the hook.
He was using a hook, and what he did was he would stick the hook through his sock, okay, and then he would put it on. And I noticed when I looked at his leg, he had long scrape marks on the side of his leg.
He probably couldn't feel it, could he?
Yeah, no, he couldn't feel it. So really, your comorbidities, things of that nature, we joke, but the comorbidities are important to remember, especially if we're messing with a question that talks about somebody with diabetes or somebody who's very obese, or somebody with peripheral neuropathies.
Right.
So just think about those in terms of contraindications. Right. All right, so we've got these devices that we used, which are referred to as
adaptive equipment.
Adaptive equipment. But are they really adaptations to us, or are they?
They would be more compensation.
Yeah.
And the beauty part about that is that you're initially helping them compensate, and then they're still able to follow these hip precautions.
Yeah. So every total hip and total knee that I've ever worked with has always been a remediation, and the remediation could include upper extremity strengthening, could include all the things that we teach them. But when we give them adaptive equipment, okay, it is going to be compensatory, and compensatory usually will last for up to 6 weeks.
Right, it's compensatory initially while they have to follow the precautions, and then as they move out of the time frame where they have to follow the precautions, and as they get more joint mobility back, then they can go back to the way they used to do it. So it's just a way for them to initially compensate for their hip precautions that they have to use.
Now, when I give somebody a sock donor or a sock aid, okay, and I give it to them, and that's the only way that they can get their socks on, okay, it's an adaptation, okay? But in the meantime, for all these other diagnoses that you're going to use it and then get rid of it, okay, it's a compensatory device. All right, so let's talk about some of the other elements.
Okay, like toileting.
Toileting.
So
perfect.
So toileting, there's some things that you might not think about in toileting. Of course, we have to make sure that the height of the toilet is going to be appropriate to where, like I'm sitting on this couch right now, I'm breaking my hip precautions. If I have a lower height toilet seat, then that's going to place them at risk of breaking the hip precautions as well.
Hips are down. Oh, not good.
So one thing you can do, you can think about an elevated toilet seat. You can think about a bedside commode. Whether you're using it as a bedside commode or a spider commode, as this one would call it.
Spider commodes. Okay. Now, the beauty part about the spider commode is that they usually come with the legs, adjustable.
And you can adjust the front legs 1 notch lower than the back legs to make sure that you're
Watch questions like that.
it so that they're the least risk of breaking their hip flexion precautions. So the front leg's 1 notch lower than the back.
Right. So what if it was reversed, right? I'd say, no, that's
no
breaking
way.
precautions.
That's right. Exactly.
Okay. So think about those kinds of things, because that's going to make a difference.
And we also have to think about, when you're toileting. This is something a lot of people don't think about. Is
when I wipe.
Well, when you wipe, we'll go over that
All
first.
right, okay.
So when you're... well, we'll go over wiping first.
All right, okay. Let's do wiping first.
So when you're sitting on the toilet and you're wiping, there you go. You're going to want to wipe from between your legs.
What?
Yeah.
I got to go this way.
Mm-hmm. Because if you reach from behind while you're sitting, you're going to have to lean forward and rotate.
Oh, that's going to get messy.
So another option.
Down. Okay, go ahead.
Right. So another option is to stand.
And
when you
like
do it standing, you're going to do it from behind.
Yeah, we just do it this way.
That's a different option if they don't want to wipe.
Just do it this way.
But
wipe
again,
behind.
They want to wipe, if they're sitting, they want to wipe from between the legs, and that's because if they wipe from behind, they're going to have to lean forward and rotate to reach it. And then if you want to wipe in standing, you're going to do it from behind, because if you wipe from in front while standing, you're definitely going to break those hip flexion precautions.
I've never had a patient that didn't look at me after I said wipe from front. They all go. I always tell them, stand up and make sure that when you stand up that you do your proper stand to get up. And then once you're up, okay, you locate your legs, you make sure you're in position, and then you wipe.
That's right.
I like that method much better. Now, we wiped. Now what comes next?
Now we got to flush.
Now we got to flush.
Yeah.
So what I don't want to do, right, is I don't want to twist around.
He's rotating his hips there.
Yeah, you don't want to do that.
So whether you're in a sitting or a standing position, you do not want to do that. So what you want to do is just like what John's doing now. You actually want to stand up, make a full turn, and then flush that way.
Yes, and balance. Yeah, I just thought I'd show you. And the balance is key, right? So you have to really be cautious and careful about that.
Exactly.
And even sometimes I'll say just go partway around and reach. Because you be to the side like this and reach.
Exactly. As long as you're not, long as you're not breaking the rotation precautions, that's the main thing there.
I'm one of those guys that tells them how bad it gets if you do break it. Oh man, the stuff that happens to you afterwards, and they're like so scared that they'll do exactly what I just did. So
and it works.
All right, so we got the bathroom. That's a good thing. We've got getting up and down, okay, for hips. Okay, we probably can use all those universally for making sure that we're just, sticking to, ADLs the way we teach them.
Yeah. Now, one of the other important things we have to think about is sleeping too.
Oh yeah.
So when they're sleeping, if they're in a supine position, we want them to have an abduction wedge in place to make sure that,
abduction.
Exactly, to prevent adduction. If they're sleeping on their side, you actually want to have them sleep on the surgical side. And the reason for
That's
that
a good
is
question.
It provides good proprioceptive input. It also places them at less of a risk of their hip adducting and rotating because it's stable against the bed surface.
Yepper.
And then lastly, they can also sleep on their non-surgical side, but if they do, they need an adduction wedge or pillows between their legs, again, to keep the hips from adducting.
So we covered a lot of ground here. So we I just remind everybody, we talk a lot about the variables, the elements that we need to know about. And, we're covering an awful lot of ground here. You hear me refer to how do you process this. I always start with diagnosis, etiology, and prognosis. I work to my client factors, okay? Once I've identified my client factors, okay, I then work to what comes next. And that is, I can see my patient. I do my history intake. I do my observation, my interview, all part of the screening. I then move to what we do next. And what we do next is 3 things. Occupational therapist, okay, will be responsible for 3 things your entire career. Number 1 is safety, awareness, positioning, and ADLs, and IADLs. That's all we do, right? All we do. It's everything. There isn't a thing in this world that doesn't follow those criteria. So when we have that, the most important thing is to identify activity demands for that person. Okay, we all know ADLs like we just did here. We can explain ADLs after a hip surgery. But what if you show up at a patient's house like I did, who's had a total hip, okay, and the only thing this guy cares about is whether or not he's going to be able to get in his tree stand to go archery hunting. Yeah, and that is not an easy thing, okay, to do when you've had a total hip. So we need to consider activity demands. And those activity demands are going to drive what we do next, because we all know that you're going to pick your frame of reference. Now, in this case, we really are using a biomedical approach, but on top of that, I would suggest to you that we're using rehabilitation, because we are using adaptations and we are modifying specific parts of a person's life, okay, to allow them to progress through that 6-week cycle to get to where they need to go. Make sense?
Makes sense.
Once we do that and we've identified it, we're constantly thinking about, where that prognosis is going to lead us and how we're going to treat it. Whether we're using a remediation approach, which I would suggest to you that we are using both, remediation and compensatory is next, and then finally whether we move to adaptation. And that's something that you're going to have to do your whole life, okay? Or from that point on for a long period of time. So that all leads us to intervention and, planning the intervention, okay, actually doing the intervention, and then your reassessment and really looking at the outcomes of what you're doing. And then it all starts over again when we change the context. So consider some of this. And, we spend a lot of time in reasoning, okay, at the OT help desk. And, with that, of course, we have thousands of questions in our product, and every one of them has a rationale, okay, that's with it. And usually most of them are through videos. And then if it's not video and it's just a straight up test, we provide rationales. So, consider that. We'd love to have you come join us. Well, that's it for today, and we'll look forward to seeing you at our next YouTube series.
And like and subscribe.
Bye-bye.